in a stepwise, logical fashion during anaesthesia, but you're much more likely to run into problems if you have to give so much induction agent. Then they don't breathe, as we've already said. Then they don't stabilise during that initial period of anaesthesia. And everything then, I think, just adds up to being those cases where we get advice saying, actually, we recovered the animal from anaesthesia because they weren't stable. And it's often that kind of pre-anaesthetic period. So the pre-anaesthetic exam and your kind of your preparation and your drug selection that causes you those problems in the anaesthetic itself. It's not what happens from induction, it's that part before then.
There's a great question there from Alana. Going into a practice where they've got set protocols, how do you best overcome that? I think one thing to point out that's really important is familiarity is best with anaesthesia. So if you're a person starting in a new practice, new job, I think what you've got to remember is that all the people that work in that practice are I hope they would be really confident with that protocol and their set protocols. So that's probably quite alien to you, but if everyone else is comfortable with it, it's quite difficult to go in there and say, look, I'm not familiar with this. Can we change things? And it's a question of whether you change that for one person or whether you change that for everybody. And probably changing a stepwise approach is the most suitable way to do things. And maybe just pick certain things. You think, well, okay, they're using acepromazine, buprenorphine as a routine pre-med. I would rather use methadone. That's probably quite an easy switch to make. And there's probably an education piece around that to make people happy with that change. And one thing you've got to remember is nurses as a group of people hate change, and you have to be very slow and very cautious with how you enact change if they're really familiar with something. You might think that switching from buprenorphine to methadone, making that the only change, is really easy and nothing's going to go wrong. But if you don't have the nurses on board with that, they'll tell you that's the worst anaesthetic ever. Then someone will have a moan to the boss, and then someone will say, well, you can't do this. And you end up in that awkward situation. There are lots of practices out there with very, I'm going to use the word antiquated protocols. I've spoken to 2 practices in the last year where they routinely still use atropine. And there's absolutely zero reason to use atropine as a routine pre-medicant these days. But practices that use it are very familiar with it, and they're very happy with how those anaesthetics run. Now, obviously, I haven't been into those practices and maybe seen how those anaesthetics do generally run. But that's just a little interesting piece of anecdote there. Yes, familiarity is best. Think about small changes first. There is now good evidence that methadone is a superior analgesic to buprenorphine in both dogs and cats. So there's evidence for orthopedics and for ovarian hysterectomy as a model in dogs. And for cats, I think buprenorphine is a fantastic analgesic in cats, but there is some evidence that methadone produces a decrease in wound sensitivity afterwards, in the post-surgical period. So if you need to be equipped with evidence to go and make that change in practice, again, that's something that we're really happy for you to contact us and we can help you out with that.
Perfect. And then another question we had, which was, how do you cope with the pet that doesn't like to go into the practice? Or so I guess these might be the really fractious nervous animals, so either kind of a nervous dog or fractious cat. So how do you cope with them in the kind of pre-anaesthetic and recovery period?
A good question, and something I think we've noticed more and more, perhaps even so over the last sort of 12 months with everything that's happened with COVID, with clients not being able to come into the clinic with their own pets. We're taking them off them, obviously, in perhaps the car park and in other areas outside of the practice. So, and those animals, those dogs particularly, are used to being with their owners all the time. I think we're all at home much more, and we've really noticed that. So I suppose 2 things here that are really important. If you already recognise that animal, that dog or that cat is more likely, or is likely to be a problem for you, then think about doing things before they come in for a procedure if possible. We really find that if they're in the hospital and then we're trying to give them perhaps anxiolytics to calm them, they're much less effective. So think about that beforehand if you're aware. Obviously, we're not always aware. And then really, I suppose, two things that have changed the way we might manage these dogs and cats over the last couple of years are the introduction of using drugs such as trazodone and gabapentin, and particularly those are the two that come to mind for me. And thinking about using those, particularly in dogs, prior to admission. So trazodone can be very useful, and we often prescribe that perhaps for 2 or 3 doses before they come to the hospital. And we certainly use that a lot. I think the nurses come to us, and our kennel area, our ward is very busy. It can often be very noisy, and there's a lot of stress associated with being hospitalised. And trazodone can be quite useful in those dogs. Gabapentin, a great fan of gabapentin in cats, and certainly those ones where they're fractious and we're going to be perhaps taking blood samples or placing IVs or diagnostics, then gabapentin can be really useful. And you can combine the two together. What I would say, something that's really interesting, one of our cats, he had to be in the hospital recently and have some sedation, and he did have gabapentin, and he was ataxic, I think, probably for about 12, maybe 18 hours afterwards. And when he came home, I was really surprised. So obviously we see them in the hospital, and we send these animals back home, and particularly cats that have perhaps had that as part of their sedation. And I was really surprised. It made me think a little bit more about how we then tell owners what they might look like when they go home. Actually, that's an expected kind of event associated with those drugs, and not to necessarily be worried, but obviously don't let them go outside. Because I thought if he goes through his cat flap and trips over.
Yeah.
So.
This is drunk from it. Yeah, it's a really important thing, because it's quite easy, I think, to overlook that sometimes, because they come round often. I mean, animals bounce back so well from everything, don't they? And then we ship them off home, and you kind of managing owner expectations. Just to kind of expand on that a bit further, with regards to using gabapentin and trazodone, do you have like a set protocol that you do? Would you give trazodone the night before or in the morning, or just kind of, either of them on the morning?
So there are 2 resources that I would recommend to everyone. I did a webinar a while ago. It's in the BSAVA webinar library on managing the behaviourally challenged dog and cat.
Perfect.
So that's there. Obviously, that's free to members. And I also work very closely with Sarah Heath, who you will be hearing from later. And between us, we've created a protocol for dogs and cats that's available from Sarah's practice behaviour referrals. Actually, it should be on their Zero Pain Philosophy website, but I'm not sure it is. I'll add it onto there. But what we found is that the feedback we've had from practices that use this protocol is incredibly good. And really the whole aim is around ensuring the emotional health of these pets is addressed, as well as making things safe for us, particularly when they're very challenging and they're difficult to manage, or where they have anxiety as an element of their problem. And I suppose the other thing I would say is, if you suddenly realise that this dog it's going to be a complete nightmare for the dog, just abort, send the dog home and think about doing it another day. Like Carl said, we often give them the trazodone the night before and the morning of the visit. In cats, as long as you give the gabapentin sort of 2 hours before they leave home, they're generally okay. But some dogs need some trazodone the night before as well. So that's all covered in the BSAVA webinar.
Perfect. That's wonderful. Cool. And then we have another question, which is about what is your opinion on using local blocks during anaesthesia? I've seen some practices use them lots and others not so much. Would you recommend using dental nerve blocks?
It's the whole reason we created the Zero Pain Philosophy.
I think I know your answer to this.
That wasn't a plant, by the way. When you're planning an anaesthetic, we should think about using opioids, local anaesthetics, and non-steroidals in every single case. So, like I say, 99.9% of cases we can use opioids. Where you've got acute pain, you should use a non-steroidal unless you can find a very good reason not to. They're licensed, they're safe, they're efficacious. And where possible, we should also incorporate local anaesthetic techniques as well. In order to make that easier for people, as well as reading descriptions in books, we thought sometimes you read a description in a book and it's quite hard. So we thought we'd just get our phones out, make videos of us performing local anaesthetic techniques every day and put them on a website. That's how Zero Pain Philosophy started. So you can get your phone out when you've got a cat dental to do, and you can find the cat dental or the dog dental video and just watch that through, just to give you the confidence to do those techniques. So absolutely, certainly cat dentals, the evidence in the literature shows that those cats are more stable under anaesthetic and more comfortable in the post-anaesthetic period. We get great feedback from people that we teach local anaesthetic blocks to. So we run a practical course 3 times a year. And the people that we teach, I really like seeing people at conferences a couple of months or years later, and they say, since we've been using local anaesthetic techniques in the practice, we've been really happy. Nurses are really happy with the anaesthetics. Pets are a lot more comfortable in the post-op period. So yes, absolutely local every time.
Perfect, cool. And then another one was, in terms of total intravenous anaesthesia, what is a good way to be introduced to using this in general practice, and what is your advice about it? Obviously, I know that kind of became quite a popular question when there were kind of shortages of inhalant anaesthetics, but it's not commonly done at the moment, is it?
It's interesting because it's still not something that we use routinely, and although I think we probably all appreciate that at some point in the future there'll be restrictions on the use of the inhalant agents because of potential things like greenhouse effects associated with them. What I would say is that you can't just switch from if you're very familiar, like Matt said before, with regard to safety, if you're really familiar with using inhalants, so either isoflurane or sevoflurane, then there's a few differences there that we associate with using either propofol or alfaxolone. They would be the two we would use if we're truly doing TIVA. I suppose what we do most of the time is what we would call PIVA, or partial intravenous anaesthesia, where we're using an inhalant agent and then we're giving infusions alongside that so that we can reduce the amount of the inhalant agent. So one of the things actually we thought about in terms of questions, in terms of common complications, so we see, I suppose in most cases, particularly I think in really small animals here, we see hypotension, hypothermia, hypoventilation as a part of our kind of anaesthetic sort of common complications. And hypotension usually because of vasodilation, because of our inhalant agent. So the higher our vaporizer set, the more vasodilation, the more hypotension is likely. So try and reduce that by using other drugs. So maybe thinking here about opioids as infusions, or ketamine, for example, lidocaine in dogs, alpha-2s even in dogs and in cats can all be used as intravenous infusions. And then we can really turn our vaporizer down to a low setting. Most important in those cases, or those patients that are sick. So if we're dealing perhaps with a patient that's got some abdominal disease and maybe a septic abdomen, things like splenectomy, other GDV, those sorts of cases where we want to turn the vaporizer down. So PIVA is probably the first step to go. I wouldn't go straight from giving isoflurane today to giving a propofol infusion tomorrow, but mixing and using combinations of both, a really good way to provide good analgesia as well as turning down the vaporizer. Truly turning to TIVA, I think it's really hard just to give propofol or alfaxolone by itself. You'll definitely run into problems. Those patients we'll see quite significant respiratory depression. If you give enough propofol to have that patient at the same depth as you would do with isoflurane or Sevo, they won't breathe in the same way that you expect them to do. So, and I would be getting really familiar with how your monitoring equipment works as well. So being used to using things like capnography so that it can guide your depth of anaesthesia, and just being aware of what complications you might see. So those are things to get familiar with first. You get used to how the animal responds during anaesthesia, get used to your monitoring equipment. Maybe in, 10, 20 years time, we'll be told that we can't use those agents anymore and we will need to switch to intravenous. But
I think I always say nothing immobilizes a patient like a volatile agent, which is very true. Like I said before, the volatile agents and the intravenous anesthetics have differing mechanisms by which they produce the immobility. And if you've seen those patients on a propofol or an alfaxolone infusion, they don't have the same muscle relaxation. So you get the leg twitching when the nurse is trying to clip the abdomen, and you do need to add another infusion alongside that. I guess the other reason would be a practice where someone's pregnant from a workplace safety. Other countries are very hot on it. So Denmark, they're really, really hot on not using volatile agents from a health and safety point of view. So you never know, we could end up that way. But people were forced overnight it was back in, I think it's December 2018, when isoflurane went off the market. I'm pretty sure on BSAVA webinar library, Ian Self did a webinar on TIVA. So again, that would be a good one to.
Yeah, I'm sure there was quite a lot of resources around that time when we had the isoflow shortage. Just another one that actually kind of again it kind of links quite nicely to the TIVA question. Was a question from Chloe. She says, I've seen a lot of vets go straight to increasing the isoflurane during a procedure when the patient becomes light or painful. Is there a better option to this?
Absolutely, yeah. So if your patient is suitably anaesthetised, and what I mean is the patient goes into theatre and we verify that our depth of anaesthesia is appropriate. So we look at our jaw tone, our eye reflexes. We from visually observing that patient, we say the depth of anaesthesia is appropriate prior to surgical incision. At that point, we take a baseline heart rate, rest rate, and blood pressure, hopefully if you're measuring that. If at any point during that surgical procedure, those values increase above 20% of that baseline, then the patient's reacting we call that nociception. So that's a pain response. And we need to give further analgesia rather than turning the vaporizer up. Okay, turning the vaporizer up might help in the very short-term situation just to control that response, but further analgesia is the answer there. So top up the methadone, repeat the alpha-2 agonist, give some ketamine either IM or IV. There are a variety of options to manage that. Yeah.
Perfect.
I suppose I'll just add there actually as well, Helen, to say that don't be afraid. If you're concerned the patient's going to move, then don't be afraid to turn the vaporizer up while you do these other things. So really important there to not get yourself into the situation where those animals may decide to try and exit
or give a top up of induction agent. Yeah, so like I said, 1 mg per kg of propofol, 0.5 mg per kg of alfaxolone as a top up. So we've always got that written down. Once we've induced anaesthesia, we will always tell the person monitoring the anaesthetic what the top up is in case that dog moves on the way to theatre or during the procedure. If we get gross movement, that's the best thing to do to increase the depth of anaesthesia.
Yeah, and you'll get kind of quite a quick response, won't you, with that as well. So brilliant. I'm just going to select the next question. So one of them was kind of around whether pre-med would ever need to be topped up. And kind of something I thought about around this was, what do you do if you have a fractious animal? And I know we've kind of discussed this a bit before, and obviously aborting is always an option. We can always kind of plan and do the procedure another day. But I've certainly had it happen to me in practice where you give a pre-medication that should be adequate for that animal. You've managed them, they're in a calm, quiet room, you've used something appropriate like an alpha-2. But they're still quite awake, they're still quite kind of reactive, and they're not in an appropriate state that you could place an IV catheter or that you could, induce them because they're just too reactive. What do you do there? Do you give a different pre-med? Do you give a top-up of pre-med? Or do you completely call it a day and try another day? What would be your approach?
Yeah, sure. Good question. Those are those frustrating cases, aren't they, where you want everything just to run really smooth. Maybe it's the first case of the day, and it's already got off to a bad start. I suppose one thing I'd always just be aware of is that we're sure that we're doing good, like IM as good as we can, an IM injection, because often I think some of these pre-meds. Sorry, that's one of our cats. One of them likes to join in. I think it's very easy for perhaps some of the drugs to not go IM. Maybe they go into fat, and we get that much slower, and perhaps we don't get such a maximal effect of the pre-medication that we've given. With those really kind of crazy, perhaps those crazy dogs, those young and healthy dogs that can often be quite challenging, then thinking about adding perhaps other drugs into the pre-med can be useful. You're giving perhaps an alpha-2 opioid pre-med. Maybe if they're those ones where you're worried, either they're kind of nervous, aggressive, or they're very worried about the situation, or you're worried about not being able to handle them just because they're so excited, ketamine can be quite useful IM in those cases as well. So I would mix my alpha-2, my opioid, and ketamine. I used to very commonly actually mix acepromazine and alpha-2 and an opioid as well. So we give all three of those drugs if they're particularly kind of worried about everything that's going on, and we're concerned that we won't get good sedation from my pre-medication. So don't be afraid to top up. We often have to top up IM. It's much less kind of reliable and much less predictable than giving drugs IV. So that would be the main thing that I would say. So don't be afraid to top up. If you give a dose of an alpha-2 and an opioid and you don't get good sedation, give them a bit more time. Some of those pre-meds may take 25, 30 minutes, so don't rush. If it's 5 minutes and the nurse is coming to you and saying they're still not, sedated, more time, definitely. But if you get to sort of 25, 30 minutes, then that's the time I would definitely be thinking about giving more pre-medication. And I might be then thinking about topping up with more alpha-2 and perhaps adding ketamine in or adding acepromazine in that situation. If you've got an IV, then, and you've given IM, maybe you've got an IV in place and they're still not sedated enough for induction of anesthesia, definitely don't be afraid to give really low doses then of alpha-2s IV if it's safe in that patient to get better sedation.
What do you mean by low doses?
Low doses, so thinking there, if you're using dexmedetomidine, probably 1 to 2 micrograms per kilo of dexmedetomidine, and medetomidine, probably again around 1 to 2, maybe 1 to 3 micrograms per kilo of medetomidine. So really quite low doses, much lower than maybe some people will have seen used for IM sedations in general practice.
And I think your patient should always be well pre-medded prior to induction of anaesthesia. If you've used acepromazine or an alpha-2 agonist, we shouldn't go ahead with anaesthesia if we haven't got the sedative effects we want. We should always do something about it. One thing that's worth mentioning, if you haven't already downloaded it, the DECRA anesthesia app has got all of the doses that we talk about and a whole load of protocols on. I know DECRA are one of the sponsors of today, and I'm currently working with the DECRA to update that app. So there are protocols that aren't on there that we are in the process of hopefully be launched after Easter. Maybe that's a bit ambitious.
No, that app, I've used that in practice and I really found it really helpful because you can kind of look for specific scenarios as well, and you can enter your patient, you can have a plan and you can then use that. So it's a really wonderful thing to use. So yeah, good source to kind of mention there as well. This one is another question is related to pre-meds. Just basically, one of the delegates has asked about when should you do your pre-med. Some practices do it kind of at admission, whereas some just do it 20 minutes before the procedure. What is better?
I remember those days when I started in practice some time ago now. We pre-medded everything at 8:30 in the morning, and some of those patients had their procedure, in the afternoon. So it's interesting that those, that's kind of still something that's around. I suppose we were generally giving acepromazine and I imagine from memory buprenorphine IM in those dogs, and that would then last for quite a long time. But they would obviously go into a kennel, they would potentially get colds, they were obviously sedated, so then we would end up potentially with more problems. So I think we should probably move away from doing that. And the alpha-2s have definitely allowed us to be better tailored because we can pre-med, as you say, probably within half an hour really of our induction time. Certainly with alpha-2s, 15 minutes. If you're giving them IV, then 15 minutes, 10, 15 minutes is absolutely fine. And that way you're not having to monitor those patients in kennels as well after they've been pre-medded. So I think that's it's probably worrying to give a pre-med and then just put them in the kennel and not be there observing them, particularly with things like the abundance of brachycephalics that we see in practice these days. So the use of IV, if you can get an IV in place before pre-medication and you're pre-medding IV, then really that 15-minute period is absolutely fine. So I would definitely recommend to moving away from kind of blanket pre-medication.
Yeah.
Perfect. And also 15 minutes gives you a chance to get brewed, doesn't it? So next thing. Brilliant. And then this one's kind of moving on to kind of post-op care. And I can definitely understand this question. As a locum, I used to see a whole variety of protocols for post-op care, and I guess there's not one size fits all or one correct answer. But this is Rosanna was asking. So for post-op analgesia, I've seen various protocols. Some vets will use for a routine cat castrate. They'll give a top up of buprenorphine later, but then no meds at home. Some won't give any top up, but then they'll do like a 5-day course of Metacam. What's best? Is it personal preference? And yeah, I mean, I'd say from practice, some practices just do 2 days of a non-steroidal, some will do 3, some will do 5, some do pain scores and top-ups of an opioid post-op, but only for certain procedures. I think there's quite a lot of variety out there. What's your kind of advice?
I think whilst the patient's in the hospital, we'd encourage pain scoring. I think you should always, like I said, you should always use a non-steroidal in your protocol. So cat castrate, cat spay, really good evidence that adding non-steroidals in with your opioid improves comfort in all of the routine procedures that we do. So really that's the basis on which we've used non-steroidals for however many years, 30 plus years. I think probably a cat castrate, a non-steroidal is a very good option. They probably don't need a second dose of opioid. I would encourage you to make sure that you've used buprenorphine as your opioid rather than butorphanol. Butorphanol is really only reserved for sedation. It's not yes, it provides analgesia, but really short duration, probably only an hour. So buprenorphine in the pre-med for a cat castrate. I think you could argue buprenorphine or methadone for a cat spay. And make sure they get a non-steroidal as well. And certainly for cat spay, home with non-steroidals for 3 days, I would say. Yeah. Another example where if that's not already happening in the practice, perhaps you could do a piece of audit work and ask owners when they come back for the post-op check how comfortable the patient was. You get a good idea of whether your practice protocol is appropriate for those cases.
And using local anaesthetic as well in those, even in cat castrations, you can do an intratesticular block with some lidocaine. Great option to kind of minimise any response to that part of the procedure. So don't be afraid to utilise those other techniques.
No, and I've got a video on Zero Pain of my approach to local for a dog castrate.
Oh, wonderful. That's a really, good resource to have, isn't it? And you've actually answered another question, which was about using local anaesthesia in castrates. Mm-hmm. Another question that we had was, and this kind of links back into what we were discussing earlier about patients that are maybe becoming lighter or painful or waking up. Demi said that she's seen some practices using midazolam for those patients. Would you use that in those scenarios?
I think we do use midazolam. I suppose the main indication for me, and not for that reason, my main reason for using midazolam is part of a co-induction. So we might use it in combination with propofol or arfaxolone, or in certain situations, other drugs as part of our induction protocol. Not really using it for controlling depth of anaesthesia, and we're not using it. It's not an analgesic, so we wouldn't use it to provide intraoperative analgesia. So in that scenario, no, it can be useful. Perhaps if we don't want to if we're just using an opioid, for example, as pre-medication, and those patients are not particularly well sedated, but they're sick, then midazolam can certainly be useful as part of an induction protocol. So that would be the main reason I would personally use it.
The other area where we consider using midazolam, you'll find it in the protocol that Sarah and I wrote for the emotionally challenged patients. In people, we know midazolam has a retrograde amnesic effect, and we don't see why that wouldn't be true in dogs. And so the rationale there is if you use it at induction, perhaps that's going to help that dog forget some of the experience leading up to the induction process. You can imagine if you're anxious and you're terrified and you have someone come along and hold you that you don't know and then jab you in the bum, and then you've got all of the other stimuli going on whilst your sedative's taking effect, then that's a pretty traumatic experience for those dogs. So if the theory holds true, then we think that that's a sensible and a rational approach to use of midazolam in those patients. But yeah, midazolam is not analgesic. Yeah. You will say that in practice, and someone will look at you as if you've landed from Mars, because people do think midazolam is analgesic, but it's not.
And just be careful if you're using it in very short procedures, because it does last probably at least sort of 40 minutes or so, and you might get the recovery of your patient impacted. Then they can sometimes be a bit disinhibited, and obviously they can have perhaps a little bit of a rough recovery. So just be aware of that if you are using it. We wouldn't recommend to use it as part of your pre-medication in a healthy adult dog, for example, unless you're giving good sedation alongside it. You might just end up again with disinhibition at that time.
Yeah, there was a paper recently comparing a methadone pre-med to a methadone midazolam pre-med in healthy dogs, and the methadone midazolam dogs were less sedated, and I think the induction of anesthesia was less smooth than just the pre-med with methadone. So yeah, young healthy dogs, it's not a good idea for pre-med.
Cool, perfect. And then another question was regarding kind of when you have hypotension under anaesthesia. Obviously, we know there's lots of reasons why you might have that during an anaesthetic. So the question was relating around whether you would switch halfway to kind of partial intravenous anaesthesia, or is there something else that you would do for those ones?
I think to start with, in those cases, really important to always actually examine the patient, check them and look at their depth of anaesthesia and make an assessment whether you think that they're an appropriate depth. Are they too deep? Can we reduce the vaporizer setting at that point? So as we kind of mentioned earlier on, the most common reason in the otherwise healthy animal to see hypotension is because of vasodilation. And that can be because of a number of drugs, but our inhalational agent is going to be the most common reason to see that vasodilation. And often just being able to reduce the vaporizer setting is enough. If they look like they're not really deep, then think about analgesia in those cases, because that's going to be another way then to be able to reduce the vaporizer setting. So that would be the kind of the first steps to look into there. I wouldn't say that I commonly switch to Tiva, but as I mentioned before, we might add in an infusion of something else to be able to reduce the vaporizer setting. So more going along the lines of Piva. So an opioid infusion, a ketamine infusion, those sort of things will definitely help your ability to drop your vaporizer setting. And don't forget to think about when you gave the pre-med as well. So if it's already an hour or so since you gave an alpha-2 pre-med, perhaps the heart rate starting to come back up to a more normal heart rate, you just might need to think about whether you need to top your pre-med up as well in those cases. So those would be the first things that I would think about doing. Anything else?
For managing hypertension?
I was going to say, what if we think that their anaesthetic, kind of their level of anaesthetic and their plane of anaesthesia is actually quite nice and appropriate, but they're still hypotensive? What would be the kind of recommendations in those scenarios?
So if you've not given a fluid, providing the patient can have a fluid bolus, you've not got any concerns, then a fluid bolus of a crystalloid, so Hartmann's, I suppose the most common of the fluids that we generally give during anaesthesia, I would give a 5 ml per kilo bolus of Hartmann's initially, sort of 5 to 10 minutes, and then reassess the patient at that point. We could definitely give a second bolus. Just important to not let the time kind of go by too quickly. The time suddenly, we have like half an hour of hypotension. Importantly, we don't really know how long you have to be hypotensive for and to what extent to necessarily see post-operative complications. But I think a lot of the time we don't ever monitor those patients post-operatively in a fashion that we would know if they've had a problem. But fluid boluses to start with, if we're then getting to that point where we can't manage blood pressure at that time, that's a kind of a more difficult scenario, because then you've got to I'd want people to be familiar and comfortable with giving any drugs to then manipulate blood pressure. And that's kind of another step on, really. And I'd probably be getting advice from other colleagues in the practice and actually getting them to come and look for you to see if there's anything that they pick up that might be different. Obviously, if you have people in the practice, the more senior vets that are familiar with using perhaps some drugs to manipulate blood pressure, then you could think about introducing some of those at that time. But I think in your otherwise healthy animal, then the majority of the time, adding analgesia, thinking about your pre-med, being able to reduce your vaporized setting and some fluid boluses, that's generally enough to manage blood pressure. It'll be those sick animals where you might need to take that next step.
I think management of hypotension is something very individual to the practice, because a lot of it revolves around what pre-med you've used. So managing hypotension associated with acepromazine is quite different to managing hypotension associated with the alpha-2 agonists. And whilst we do commonly use a fluid bolus as a first line, it's not always the most appropriate thing. Sometimes we might need to fix the heart rate. Is the heart rate inappropriately low? If you've used a big dose of an alpha-2 agonist, and by big dose I mean kind of 20 micrograms per kilo of medetomidine and more in a dog, your heart rate will be low, your rhythm will be irregular, and probably your blood pressure, your oscillometric blood pressure machine may give you spuriously low readings, even though we know that in the early stages and after 20 mics per kilo of medetomidine IM or IV in a dog, you should have a higher blood pressure. So high, I don't really use the word hypertension, but your blood pressure should be adequate for at least an hour after that. But during that time period where you've got that bradycardia, perhaps your oscillometric monitor just can't cope with that. So I think you do have to ask yourself, do I genuinely believe what my oscillometric is telling me? And that comes down to a knowledge of the drugs that you've used.
Yeah, that's a really good point, particularly with alpha-2s. Someone has asked actually about using dobutamine as a common option for kind of blood pressure. Is that kind of third line step? So obviously you manage, are we the right depth? Are we hypertensive because maybe we may be a hypovolemic or benefit from a fluid bolus? And then obviously the next thing would be things like vasopressors. I don't know if you have anything further to add, because I know that you've already mentioned reaching out to colleagues with more experience for those ones. But I thought I'll read it out for you in case there are any further comments on that one.
Probably dobutamine is probably the one that we use less in small animal practice. I think for most of the students here today, they will have seen potentially dobutamine used in horses, and that's probably the most common scenario, the large animal species. Generally, we would probably be selecting dopamine or maybe noradrenaline in small animal practice. There is another drug that some of the students may have seen as well, which is ephedrine, which is a much shorter acting kind of bolus administration drug, and that's something that we can consider. But again, I would probably strongly encourage everyone not to just get these drugs out of the cupboard and start using them unless you perhaps had some kind of training or you're familiar with their use, because it's easy to then perhaps create another problem by using them that you've then got to manage. So I think much more importantly, those things that Matt mentioned there with regard to just being aware of what drugs you've given and really just looking at your patient and making an assessment.
Perfect, cool. And then we've got a couple of questions more kind of focused around neutering. So I'm going to ask them in combination. So the first part of the question is, what's your opinion on doing cat castrates under sedation versus general anaesthesia? And the second question was, are there any benefits of using a quad over a triple protocol or vice versa for cat neuterings, that'd be cat spays and cat castrates, which are often used in the charity clinics?
I think for cat castrate, you could certainly, it depends on what you define as sedation. If you've used, let's say you've used medetomidine and an opioid, if we you're going to use enough medetomidine to immobilize the cat, keep the cat still. Medetomidine offers sedation and analgesia. Analgesia at higher doses in cats. In conjunction with opioids, they have a synergistic effect from an analgesic point of view. So I'd say methadone or buprenorphine as your opioid. Remember, buprenorphine slower onset of action, probably 30 minutes before we see full analgesia. If you combine that with a local anaesthetic, I don't see a reason why you should do a cat castrate under that. Don't forget, comparing that to an anaesthetic, if you convert that to anaesthesia, you use propofol, no analgesia, you maintain on ISO or SIVO, no analgesia. So I'm thinking from what produces immobility to enable us to do the procedure and provides a suitable level of analgesia. So that's how I think about that. If I was actually to add ketamine to that picture, which is what I would do, which constitutes what people refer to as a triple. So your traditional triple is medetomidine, butorphanol, ketamine. I would encourage you to replace that butorphanol with either methadone or buprenorphine in your triple combination. Certainly, I'm most familiar from the approach I took in practice, which was using a triple combination with buprenorphine to spay cats. Comparing that to the quad, I think the quad is a really useful protocol. So the quad is medetomidine, ketamine, midazolam, and then either methadone or buprenorphine. It was developed to facilitate early neutering in cats with a group of anaesthetists and I can't remember David's surname at the RSPCA. I'm sure it's David in the RSPCA in Manchester. And they have the kitten quad app. So you put the cat weight in and say whether you want to use methadone or buprenorphine. And all the volumes of drug are exactly the same. So your methadone, your ketamine, your buprenorphine, and your midazolam. I think it's a really effective option. If you think about those wriggly little young kittens, there's probably no way you're going to place an IV in those for IV administration. And the quad is an IM option, which works very effectively. And it's something that I encourage our residents to use. On the rare occasion we have a cat spay, which is normally a staff pet in referral practice, our residents need those cases for their casebook. So I encourage them to use the quad for experience. I think it's a good combination.
Yeah, and it's handy having the app as well. I think it's James Yates, if I remember correctly.
James Yates and Dave. I can't remember David's surname.
Yeah, he kind of came up with that. Brilliant. I'm just going to scan through. We've probably got time for one more question, although I think you guys might have answered all of them, which is wonderful. So I'm going to check if there are any on the discourse as well. Okay, yeah, this was one that I had from a friend who's just started in practice, and it was about kind of cuff pressures with ET tubes. So kind of what's your thoughts on using them? So some people use cuffed ET tubes in cats. Other practices are adamant that you shouldn't use them because of the risk of kind of necrosis there from the pressure. And should we be measuring the pressure we put in? Because often it's kind of an arbitrary amount that goes in a syringe and cuff puff for it. But should we actually be using like a manometer to actually measure the amount we're putting in? What are your thoughts on those?
I suppose first thing to say is yes. I mean, we use cuffed ET tubes in cats every day, and I don't have any reason why we shouldn't do. So I think I would encourage people to use cuffed tubes in cats for the main reason that the reason the cuff is there and the reason we place that and we use it is to make sure that airway is protected. And if you don't have a cuff tube in place, then there is a risk that the airway is not protected. And if that patient was to either regurgitate or something else entered the mouth, and there's a potential for that to end up obviously tracking down into the trachea and into the lungs. And I suppose the second part to that is then we'll get contamination of the environment with your inhalant agent as well. So whatever you're using, SIVO or ISO, has the potential to leak out into the room, and you obviously can't scavenge that gas as well, that inhalant agent then. So that's something else I would think about. I think what's really important though is for people to think about what types of tubes they're using. So we wouldn't recommend, for example, to use the red rubber tubes in cats and then cuff them. Wouldn't recommend to use them full stop. And there are various types of other types of tubes, depending whether they're PVC based or whether they're silicone based. And one of the real problems with, although people do measure cuff pressures, and they certainly do in human anaesthesia, that would be gold standard and would be recommended to measure, and even in some procedures, monitor cuff pressure during the whole procedure. There's two things we don't know, is that the different types of cuff and the different types of material means that the pressure is not necessarily reflective of what the pressure is on the tracheal mucosa. So that's something that's been discussed recently, and that makes it challenging to say what we should set the cuff pressure at, because you might measure it and think it's high or low, and then you place another tube and you still get the same sort of reading. So it's quite hard to interpret that information in the face of actually what's going on. So we would just encourage people really to actually look to see how much volume they need to place in the cuff. So we would call it a leak test, where you would obviously intubate the patient with an appropriately sized EG tube. And interestingly, we have some information that says it should be about 70% of the diameter of the trachea. So we don't want to place too big or too small a tube. And then we would give a breath with the breathing system, ideally probably to around 15 centimeters of water. If you can measure that, listen for a leak, and then put air in the cuff until you can't hear that leak anymore. So perhaps doing that in perhaps a bit more of a controlled manner than just putting 0.5 mil or 5 mils or whatever amount of air that you might need to place. So one of the things I would say that we have problems with are the types of cuff. Some of the cuffs are these high volume, low pressure cuffs that you'll have seen. They're quite square when you inflate them. The pressure generated is then spread over quite a big surface area, so they're less likely to cause trauma, perhaps necrosis, ischemia to the tracheal mucosa, but they don't become flat around the tube. So as you try and introduce them, they often get stuck. I'm sure people have come across this as a problem. The silicone tubes are really nice because the cuff becomes flat with the diameter of the outer diameter of the tube, but the cuff itself is not uniform once you've used it a few times, and you can get it inflating on one side and not on the other. So I find those really challenging, and they often, you feel like the cuff's deflated. It hasn't, it just moves, and they can be quite frustrating. So yeah, the difficult ones really, but I think most important, intubate, inflate the cuff by doing the leak test to make sure that you just put in the smallest volume of air that you need to.
Perfect, brilliant. I think we're now at time, so I mean I certainly learned a lot there, and I'm sure the students have as well. If anyone has any further questions, you're welcome to put them on discourse, and then we can kind of are you guys happy to answer them on there in the next week? Perfect. Yeah. And we can kind of cover them, but it looks like we've managed to cover pretty much all of the questions, so thank you guys very much for your time and joining us today.
Great stuff. Thank you.
All right, cheers. Bye.
Bye.
Brilliant. So we're being joined by Sue and Linda. So I'm just going to unmute you both.
Hi, Helen.
Hi there.
Hi, everybody.
Hi.
So, Helen, I understand the format is this. If I just briefly introduce what we're going to do, and then we're going to play a small presentation. Is that right?
Yeah, that's absolutely grand.
So do that. Okay. That's fantastic. So I'll just start by saying thank you so much, everybody, for joining us. It's great to see we've got so many people on a Saturday morning. I know how precious people's weekends are. Thank you to BSAVA for allowing us to come and present this, which is absolutely great. Congratulations to everybody at BSAVA for putting on such a fantastic event. Helen, Alison, I know you've driven this, so well done. Enormous thank you to Linda. Linda is Director of Education at the Royal College, has been hugely busy over the last, always hugely busy, but particularly busy over the last few months. So we really appreciate her taking the time to come and chat to us today and to answer questions. this is all about Vet GDP. The Vet GDP is something that will be launched this summer by Royal College, and this is not a barrier to new grads getting the job that they want. This is not a barrier for you to going into the practice that you've chosen. This is a bridge. This is a bridge to help you become really competent, confident, resilient veterinary surgeons. There should be no reason why any practice should not be able to host a new grad. And we hope that if you listen to Linda's presentation, plus a lot of the stuff that's going to go out over the next few weeks and months in the media, that should become really, really clear. We've had huge engagement from the profession so far. We have, Linda tells me this morning, up 850 vets sign up to be GDP advisors. So there's going to be no shortage of people out there, and every single practice is going to be capable of supporting a new grad in practice. So there should be no reason why that shouldn't be possible. We've had people sign up from all over the country. I believe we've got them in the Channel Isles, and we've got them in the Highlands and Islands of Scotland, in the deepest, darkest parts of Cornwall and Devon. We've got them from all age groups. We've got them from independent practice. We've got them from corporate practice. So there will be the opportunity for everybody to go to a practice that they want to. So hopefully that will become even clearer when we see Linda's presentation. And please throw stuff into the chat box for us, and we're going to take some questions at the end. We don't care what you ask us. That's what we're here for. There's no such thing as a stupid question. Please ask. Linda, anything you want to add as an intro before we go on?
No, not really. I think you've covered it, Sue. Just to maybe signpost that we last night did update some of the information on our website. It's more aimed at vet GDP advisors and how to become one, but we are updating that information all the time.
Okay, thank you. Helen, do you want to, over to you?
Sorry, I just had a technical glitch. I couldn't hear you then. What did you say, Sue?
All yours, go. We'll play the presentation.
Cool. Is this the Kahoot presentation?
No, this is the pre-recorded presentation that Linda has done, I'm hoping.
Oh, okay.
That we should have.
I will just see.
Helen, Jenny's resent it this morning. So
okay.
It'll definitely be in your email system.
Yeah.
If it's harder to find from anywhere else.
No, just loading.
Fantastic. That's great.
Wonderful. So if I share my screen and then I can get that one playing for you guys.
That's great. Thank you, Helen.
Brilliant. Can everyone see that?
Thank you. That's great.
Perfect. I'll press play.
With no sound.
Veterinary surgeons, and it's my real pleasure to be here today to tell you all about our new veterinary graduate development programme, or the Vet GDP, that we're rolling out this year. So just to give a bit of overview, I'm actually going to start by going back into the context of this and why it's been developed, and look at the background to how it's been developed and how we've consulted with the profession to find out what good looks like and really what would benefit graduates when they first start practice. And then we're going to look at the programme itself. We're going to talk about the aims of Vet GDP, how it will work, and then some of the roles. So the Vet GDP advisors, how to become an approved practice or workplace, and some of the quality assurance that will be in place. So to look at the background, so it was in 2007 that the RCVS introduced the PDP, the professional development phase for new graduates. And this was based on a long list of year one competencies, which in turn were derived really from the day one competencies, incorporating additional experience. And the aim of this programme was to support graduates in practice. Graduates were encouraged to identify a mentor in practice themselves. The programme itself was based on self-assessment, and the link with the Royal College was they would have support from a PDP dean over email. Around 10 years after the programme had been running, we commissioned a formal evaluation of the programme to see if it was doing what we wanted it to do and if it was being effective in supporting graduates. And what we found out wasn't really a surprise, but unfortunately it wasn't. And the headlines from that evaluation were that the PDP was considered by many employers and graduates alike, unfortunately, to be a tick box exercise. The availability and quality of mentorship within practices that graduates were able to find was highly variable. There were some practices that provided extraordinarily good mentorship, but there were other graduates, a significant number, who either weren't able to get a mentor in the practice or their mentor wasn't able to spend much time with them. We found that the year one competencies, which were one size fits all really, were not always relevant to everybody's job. But what we did find is that graduates still wanted and would really value support in their transition into their first role. But it needed to be more structured, more relevant, and meaningful to that individual. So on the basis of that feedback, we knew that this wasn't a case of tinkering around the edges PDP to improve it, and we actually needed to invest in the development of a whole new programme. So at that point, we really needed to know, okay, well, what does good look like? What would give graduates the support they need? And so we consulted with the profession. This was through our graduate outcomes consultation, which was launched at the end of 2018, reported in 2019. And this was the most important review of veterinary education in over 20 years in its entirety. And there were four main areas that we consulted on, and one of them was the graduate development programme and what should it include. We had a phenomenal response to the graduate outcomes consultation, which was even more reassuring as the consultation itself was very lengthy. It wasn't just a short questionnaire. So people really invested their time into telling us what would support graduates. We had over 5,500 individual responses. And in addition to that, 38 formal organisational responses from stakeholder organisations. So in terms of the postgraduate programme, the headlines from the consultation told us that there really was an appetite for radical change. The profession wanted our CVS to be brave in this respect and actually make sure that something was in place that would really support graduates in their first job. It needed to be a complete move away from a tick box exercise. There needed to be a genuine supportive working environment for each graduate and some additional structure to the programme to support development, however, with flexibility to make it relevant to each individual rather than a one-size-fits-all. There needed to be clarity on interventions and descriptions, and the graduate outcomes consultation had two very specific questions for the profession. Should the RCVS have a role in accrediting the programme, and should RCVS have a role in quality assuring the programme? And the answer to both of those was yes. So on that basis, it was clear that we needed a completely new programme, and that's what the Vet GDP is. It must be meaningful, offer personalised support and feedback as required to graduates in their first job, and a more holistic and flexible structure was needed so that the programme's directly relevant to each individual, no matter what role they go into. One additional bit of context that I wanted to explain is around what some of the aims of this project. So one issue we do have in the veterinary profession are high levels of attrition, sadly. So a relatively high number of vets leave the profession. And a lot of those leave within the first 7 years, which is especially sad. And the RCVS runs a survey of the professions every few years. And the most recent one did include questions on perceived levels of support and types of support around mentorship that happened in the workplace. And the results of that were really, really interesting, in that new graduates did say that they were significantly more likely to stay in the veterinary profession if there was genuine, meaningful support in practice, but also in that role particularly. So the aims of the Vet GDP are to provide consistent, meaningful and personalised support for new graduates as you enter the veterinary profession, to further develop your competence beyond the day one skills that all graduates have into fully independent and experienced practitioners, and to enhance your confidence and your ability to reflect and recognise your strength as well as your areas for development. So if we take a look at the Vet GDP programme itself, so the postgraduate period is structured around real practice. Okay, so there isn't a list of year one competencies that might not be relevant to your role. Your role is what the structure of the programme is. So it's the activities in your job description that you do on a daily basis that form your portfolio and structure the programme. And we've identified high level, they're called entrustable professional activities, or EPAs, but essentially these are just high level descriptions of what you do in your job. So they're not lists of individual competencies. It's about putting all the jigsaw pieces together into real practice and dealing with consultations, etc. So we're progressing from individual day one skills, and the way you progress through the programme is actually to cover the full range of professional contexts. So although you're day one competent on your first day, it's the experience you gain through the programme is looking at different case complexities, different levels of client cooperation, different species. It's all the additional context that makes things more challenging, and that's the experience you'll gain. The meaning of entrustable in Vet GDP is very different to where these are used in medicine. So in medicine, this is about somebody being able to practice independently once they have been assessed formally in an EPA. That's not how we are using these at all. You are independent practitioners from day one. So this is about you and your Vet GDP advisor being confident that no matter what comes through the door in terms of this activity, you feel fully able to deal with it without any additional support. So we need the programme to be flexible across different roles, like I've mentioned. So we've already developed a bank of high-level EPAs that can be applied across any workplace context. And if there is a niche area in your job, then there's a template where you can develop your own EPA, and we'll support you in do that. So when you start the programme, you and your advisor will identify the areas or the activities that will be relevant to your role. And essentially each of these high-level global activities will be a chapter in your e-portfolio. So there are no scores, no tick boxes or numbers. It's a purely qualitative approach that's meaningful to you. So this is about you reflecting on your progress through each of the activities in your job. So this is just a visual really of how we envisage the Vet GDP. So once you've identified the different areas, the activities in your role with your Vet GDP advisor at the start, essentially, you are just doing your job. You will do the activities that you do every day, and it's about, this is led by you. So you're the best person to identify which areas you feel you need most support on. And that might be a discussion before a particular case, or it might be a debrief afterwards. Equally, there'll be other types of support that you request. And it's about getting that support and feedback, reflecting on your progress, and then identifying any areas that you want to practice more, or any areas that you feel you're already really confident in. So some of the activities that you can expect from your Vet GDP advisor So coaching and mentoring. You could ask for support in setting realistic goals around a particular area. We think observation and feedback will be key to this programme, and it's about you getting that benchmark from someone else with experience to support your own reflections. And it may well be that you feel you didn't do particularly well in something. Actually, your advisor may tell you, no, that was really good, and you should have more confidence in your own abilities. Equally, it may be something that you didn't realise that you could do in a different way, and they'll give you valuable feedback in that respect. So if it's a particularly challenging case that you've not seen before, and if you request it, you could also ask for assistance for it. You could ask for advice in advance of a case, for example, or your debrief afterwards, a case discussion. And then your vet GDP advisors will help guide your reflections through discussions about your progress, and also do monthly progress reviews across all of your EPAs. So this is just an example, really, of one of our EPAs that's in the bank, and it's just to highlight and give you an idea that they are particularly high level. So develop a diagnostic plan and interpret test results. And as day one competent graduates, you will already be able to do this for the straightforward cases, but what we're aiming for by the end of the Vet GDP programme is for you to be able to do it, as I've mentioned, no matter what comes through the door. So this is a success criteria on the bottom. So it could be across all different animal species that are relevant to your role, different clinical presentations, acute chronic conditions, different case complexities or data ambiguity, different degrees of client support and cooperation, or perhaps different size populations. And it's once you've experienced all of those that you can really see that you're independent, confident, no matter what, in terms of this activity. So this is, I realise you can't see the detail on this. This is just, again, it's part of our guidance. And it's a visual just to show you the types of things you'll be doing when you reflect on activities. In reality, we're building an e-portfolio, so there won't be any paper forms to fill in. But this is just to highlight the way of building this is to identify which EPA is there, which professional skills are involved in the activity, and it might be identifying some of the context that we just talked about. So case complexity, if it was a routine case or a highly complex case, and species of the environment. And then it's really about you recording your reflections on what areas were challenging, where you think it's completed well, and any areas for further development. And a similar process can be done by your Vet GDP advisor when you ask for observation and feedback. And then the guided reflection discussion can compare their feedback with your own reflections, and I think that can be particularly valuable. So in terms of recording progress monthly, this is just a guide, but it's around looking at each activity, each EPA, and really reflecting on where you are on the journey from what might be day one competent on the left-hand side to fully independent, competent, confident practitioner on the right-hand side. So this is just a guide for you and for your Vet GDP advisor to look at each of the different contexts, whether it's across different species or case complexities, and understand how the experience you're gathering is helping you progress. So in terms of recording, we're developing a bespoke e-portfolio for the Vet GDP programme. And this is an intuitive recording platform based on our One CPD recording portal and our One CPD app. So the app won't be available till later in the year, but the recording platform will be available for when the programme is rolled out in the summer. And it's really intuitive, and it means that recording your reflections isn't about sitting down and typing in and it really onerous. Actually, we've made recording reflections much more feasible. So it's about, you can use text or audio capture and upload it instantly. Similarly, you can upload photographs or documents and things like that. So it shouldn't be onerous. In terms of finishing the programme, so as you progress, we envisage that you'll probably be requesting different levels or different types of support from your vet GDP advisor. And at the point when you and your advisor agree that across all the activities in your role, so all the EPAs, that you've got the breadth and depth of experience and the confidence that you feel you need to practice without any support, no matter what comes through the door, then that is the point where you would submit your e-portfolio to our CVS, where it'll undergo a peer review and sign off. So in terms of hosting the programme, so the long-term vision is that workplaces will need to have a trained vet GDP advisor in the practice in order for that practice to become an RCVS-approved graduate development workplace. In order for a practitioner to become a vet GDP advisor, they need to complete an e-learning package and sign a declaration to commit to providing some support for their graduate. And this really ensures that all the vet GDP advisors understand how the programme works and are able to support you as needed. So there's around 1,000 graduates expected, I believe, this year. And already, even though the announcement about the programme was only a matter of weeks ago, we've already had 809 vets have registered their interest to become vet GDP advisors, which is absolutely phenomenal. And we're really, really pleased about this. They're located throughout the 4 nations, each with an average of 15 years on the register. And the training is under development at the moment and will be available from April. So as this year's graduates are looking out for jobs, they should look out for practices that are an RCVS approved graduate development practice or are intending to become one. We're really, really aware that this year, first of all, we're rolling out the programme. So don't worry if you don't see the logo on the website or anything. In fact, as long as they have signed up and show their commitment to the programme, they don't need to have completed the training. Practices may be working towards it, and even if not, have a discussion with them. Ask them if they're aware of the programme. If they're not, they can contact us, and as long as they're willing to sign up to support you, that's absolutely fine. Okay. If anybody has any questions, please feel free to email us. We're at vetgdp@rcvs.org.uk. Thank you very much.
Thank you. Thank you.
Sorry there for the slight technical issues with the slides sharing. It will be available on the discourse platform after, so if anyone wants to watch that through, they can get all of that information there as well. I'll hand over to Sue.
Thank you, Helen. And obviously, if you go onto the Royal College website, as Linda said, there's lots and lots of information there. And there are lots of frequently asked questions, which will hopefully cover a lot of the problems that people think they're going to encounter, but they are not. Helen, are you monitoring stuff in the chat box? Do you have questions coming through? Do you want to go through those, and then Linda and I can perhaps answer those? Shall I perhaps say, first of all, one of the things that's come through on the discourse platform, Linda, I don't know whether you want to reassure people, is the question that new grads cannot go to a practice if they're not registered with vet, if they don't have a registered vet GDP advisor. Do you want to just advise on the process that's involved with that?
Yeah, like I said in the presentation, that is the longer term vision, but we're aware, first of all, we're rolling this out this year, and also we're aware of the increase in restrictions due to the pandemic, which has happened since the initial announcement. So our websites were updated last night, and to tell the profession that what we're looking for at this point in time is engagement. So we want someone to have signed up to become a vet GDP advisor, so that you, as a new graduate, have that support in place, and we would want them to have started their training. But we recognise that many practices and individuals have a lot of challenges on the go with the pandemic. So it's not a requirement to have finished the training, the online training, in order to be able to support the graduate this year.
Thank you. I notice on the question there's one about, is it possible for students to complete their vet GDP whilst on a rotating internship straight out of vet school? And Linda will correct me if I'm wrong. The beauty of the vet GDP is the EPAs are personalised. So what you can do is you can design with your advisor what your EPAs are going to be. So it's right, Linda, I think, isn't it, that it doesn't matter what aspect of clinical practice they go into, they should be able to adapt it to suit their needs. So if you're up in Aberdeen and in cattle practice, or if you're in a rotating internship in a large animal referral, a small animal referral hospital, it's still adaptable, which is the beauty of it. It can be tailored to your own personal needs. Is that a fair comment?
Yeah, absolutely. And we have, so the bank of EPAs that we have are pretty much going to cover most circumstances, but there's a template where you can develop your own. And I would add that, the EPAs are there to provide you with a framework for your e-portfolio and your activities. It's your job and the activities in your job which will be the main thing. So if there isn't something covered, then yes, we can help you make sure it is.
And then there's another question here which says, is there a way that new grads can search online to see if a practice has registered their interest in the Vet GDP programme before applying for a job? I'm not aware there is anything, but presumably that's just a conversation they need to have with the practice. Linda, would you agree?
Yeah, for this year, that's probably the easiest way of doing it. So you might, if they have completed the training and become an RCVS approved graduate practice, then they will be able to have a logo and an award they can put on their website. But the reality is that many will have started but not completed and won't have that yet. We are going to get something up and running, hopefully, to put this information on Find a Vet, but it's not there yet. So we're concentrating on getting the programme and the training ready. So as Sue says, for this year, the best thing to do is have a conversation.
And we have another question about the costs that are involved. So costs as far as the Vet GDP advisors are concerned, and costs for the new grads. And there are none, are there, Linda?
No, the training we're developing will be free and flexible, so it'll be online and everybody will be able to take that wants to become a Vet GDP advisor. Also, in the longer term, Education Committee has approved that we can make that CPD free to practices that are willing to take students on EMS as well. So no, there's no costs to either party.
I mean, there will be, if I remember rightly, 20 hours for Vet GDP advisors to do. It's all free. They can complete it as soon as they can, I think is what we're saying, isn't it? Because we recognise they've got lots of other demands on their time. And it counts as CPD for them. So it contributes towards the 35 hours that vets have to do anyway. So I can see there are no negatives to this for vets in practice. It will help them. And also it's a CPD requirement. I suppose the other thing also to mention, Linda, is people who go abroad and then come back can potentially use the Vet GDP as well. Yeah?
Yeah. So if somebody does go abroad for their first job, if they want to do Vet GDP when they return, if they feel it would be helpful to get that support, then it will be open to them. But if they don't feel they need that support, it depends on the nature of the job they've been doing overseas, then they wouldn't be required to. So that's something our committee would look at on an exemption basis.
Well, there's one more question that kind of links to something that's on the discourse as well. It was kind of how it would work alongside the corporates that offer their graduate schemes. And then also kind of further to that, is there meant to be kind of one person per practice, or what about branch practices as well? How will it work in those environments where maybe you've got kind of 8 branches and the new grads maybe only at 1 or 2?
Do you want to chat, Linda, about the conversations you've been having with corporates? Because I know you have chatted to pretty much all of them now, haven't you? Yeah,
so the main thing to say is this programme puts all practices on a level playing field. So the corporates do have some graduate programs, and they vary in their content, and some of them are really, really good. However, we want to put everybody on the same level. So independents, corporates will all take the same training and do this program. And it may well be that they do some corporates do things in addition to that, but it's not a case of if a corporate has a program that can they're exempt from the having a vet GDP advisor. Everybody is the same.
And what I would say as far as new graduate programs are concerned, a new graduate program shouldn't just be sitting you down and lecturing to you. It should be the mentorship, the coaching, the reflection, and that's what's built into the training that's being designed and will be launched in April. It's a lot more holistic than just lecturing to you. It allows you to develop your own personal confidence and competence within particular fields. So that's why it works so well.
Yeah, and I didn't answer the second part of that. The point, Sue, you said I'd spoken to, I think, most, if not all of the large corporates, and they are all completely supportive of this programme, absolutely, and interested in finding out more and coming on board, which is lovely, as well as a number of independent practices that have been in touch.
And then I suppose the other thing was about branch practices and the location of where that advisor would be within the whole practice. So if it's a practice with 3 branch practices, do you want to just talk through that?
Yeah, the ideal situation is that the vet GDP advisor is in the same practice as the new graduate, and because it's all those ad hoc opportunities for discussion or observation or anything like that. However, we recognise that there are different formats out there. So the requirement is that the vet GDP advisor spends sufficient time in the same practice as you to offer you the support. So they may not need to be there all the time, full time, but as long as they are there for you to have support from.
And then we have this question again, which has come in about this nitty-gritty question as to, can I get a job at a practice if they don't have a vet GDP advisor there? So short answer is probably no. But the long answer is, Linda?
So if they're not already an RCVS approved graduate development practice, if they are, then that's obvious. They've done the training, they have an advisor in place, and they're ready to start the program. If they don't, then I would speak to them and say, have you signed up to be part of this? And if they have, that is absolutely fine. If they haven't completed the training, that doesn't matter. They can still support you in your vet GDP. If they haven't signed up or haven't heard of this yet, which I would be very surprised because we've emailed the entire profession, but if they haven't, then it's a case of asking them, will they support this? Are they prepared to support you as a graduate in your programme? If they say no to that, then that is the only situation. I imagine that very few and far between, but that's the only situation where I think that becomes difficult, because all new graduates are required to do this programme, and you're supporting you is part of that. What I would say, if that's the case, then do ask them to get in touch with us, and we can try and support them. If it's a case that they're worried that they won't complete the training in time, we can reassure them that actually now there isn't a deadline for the training. So it's a case of signing up and engaging with the training, but there's longer for them to complete it. So there might be something we can do to help. But no, the vast majority of practices, we should be able to support you. And that's what's important. We've heard from the profession that, although many graduates get excellent support, an awful lot don't, despite their best efforts. And RCVS wants to do something about that.
It's really, really important that you guys are supported when you go into practice. We know that. We know that we have a problem with the profession. We know we have very poor retention rates. And part of that is because people are thrown in at the deep end. And if you swim, that's fantastic. But if you sink, that's really not acceptable. So, this should be attainable by every single practice. And as Linda said, college are completely approachable on this. There's email addresses, they can pick up the phone. There's no reason why we shouldn't see really wide engagement with absolutely everybody.
There's one final question, which was just that what happens if the advisor leaves partway through?
We've thought of that too, Linda?
Yeah, that's a really good question. And so things do happen, obviously, and we would work with the practice to get a replacement advisor as soon as possible. And we are looking at other things as well, which haven't been finalised yet, but things like the potential for locum advisors and that to fill those situations also. But that's not been fully worked out yet, the detail underpinning that, but it's going to be discussed quite soon. I think part of that question as well, is it one advisor per graduate or one advisor per practice? Well, the important thing is that each graduate has a minimum amount of support and a one-to-one support. So it may be that some larger corporates, for example, and they haven't indicated this, but it's possible if they have an individual who wants to support multiple graduates and may do so. But equally, I think that the vast majority will be a one-to-one situation in each practice.
Okay, Helen, any more questions?
I think you've answered all of them. There was one, is there a completion of the programme where they're no longer considered new graduates?
Do you want to take that, Linda? Or
Yeah, I mean, this programme isn't time-bound. We envisage it will take about a year, a little bit like PDP. But if it's shorter than that, that's fine. If it's longer than that, absolutely, that's fine. It's when you and your advisor feel that your portfolio is ready, and then you'll submit that to us and it'll be peer reviewed by a different vet GDP advisor and signed off at that point.
And I suppose the thing is also true if people change from one type of practice to another. I know I started in mixed practice and then went into small animal practice. They could resurrect components of the vet GDP, I suppose, to support them as they change practice, Linda. That would be entirely appropriate.